Thank you. And first, I would like to thank the organizers for the invitation to speak about this topic. And in the era of precision medicine, breast cancer is perhaps one of the best examples for its implementation in cancer, and that's what I'm going to talk about today. How do I move it? Okay. This talk focuses on metastatic breast cancer, and I will discuss the 4 main principles that underlies targeted therapy selection. The first one is oncogenic addiction. The second concept is synthetic lethality. And then I'm going to tie both tumor mutational burden and efficient mismatch repair to response to immune therapy. And of course, I'll give examples for each of these principles. First, let me start by describing the Bilbao effect. Bilbao, as you know, is a port city in the Basque region in Spain, and during the early 90s, it was a city in decline due to failing industry. The city gambled on the star architect Frank Gehry's Guggenheim Museum, which opened in 1997. The museum really transformed the city and boosted its economy to the extent that in 2016, there were more visitors to the Guggenheim in Bilbao compared with the one in New York. So Bilbao effect stands for a single change that induces a transformation, and for precision therapy to become a Bilbao effect, what we need is we need to identify those driver mutations which drive oncogenic addiction. And what is actually oncogenic addiction? So oncogenic addiction means that tumors are continuously addicted to a growth signal from an oncogen. And on this basis, we recommend therapy. We consider off-label drugs or offer patients participation in clinical trials with drugs that inhibit activated oncogens. And oncogenic addiction may result of driver mutations like HER2 amplifications or mutations, NTRK fusion, ESR mutations or fusions, and so on. And for the interest of time, I will focus on the first 3. So perhaps the most iconic example for oncogenic addiction is the HER2 oncogene, which is amplified in about 25% of all breast cancers. Because HER2 positive cells are so dependent on HER2 signaling for survival, drugs that target the HER2 transform the outcome of patients with HER2 amplified tumors. And the first example, of course, is trastuzumab, which is a humanized monoclonal antibody that targets the extracellular domain of the HER2 receptor close to the membrane. Pertuzumab is another antibody which blocks the heterodimerization between the HER2 receptor and HER3, which this dimerization is the most potential activator for intracellular signaling that originates from HER2. Although both antibodies are very efficient, still there is a synergistic effect between chemotherapy and these antibodies, and we usually administer them together. Otherwise, response rates from the antibodies alone are relatively low in the range of 20%. This is practiced in a drug called TDM1, which is an antibody drug conjugate that comprises trastuzumab and a chemotherapy called maytansine. When maytansine was given alone systemically, it induced a lot of toxicity, but when it is combined with trastuzumab, trastuzumab leads the drug into the tumor cells where the chemotherapy is released with very little collateral toxicity. And last are small molecules like lapatinib and neratinib, which block the internal part of the receptor. And all these drugs I mentioned have been proven efficacious in phase 3 trials and were granted approval by the drug regulatory authorities. So according to guidelines, therapy in all lines includes anti-HER2 therapy because tumor cells maintain their HER2 addiction. And for example, in phase 2 treatment, in first line of therapy, the regimen includes trastuzumab and pertuzumab together with a taxane. And this regimen proved effective in the Cleopatra trial, which is a phase 3 trial that included pertuzumab, trastuzumab, which I just mentioned, with taxane. Results demonstrate response rate of 80% and median overall survival of 4.5 years. And you should believe me that these are unprecedented results to the extent where it is really not uncommon to see patients with no evidence of disease after several years of on this protocol. And the question now is whether these patients are cured and maybe we can stop the treatment. And just to make things clearer, usually after 3 to 6 months, when patients get maximal response from this regimen, we usually stop the chemotherapy and patients continue maintenance therapy with anti-HER2 drugs. So the role of anti-HER2 therapy in HER2 amplified tumors is already well established, and there are other druggable genomic alterations, but we don't have yet inhibitors for those. These therapies are being tested in early phase clinical trials, but the problem is that these mutations, these alterations are quite rare, as you can see they appear in the long tail. So in order to conduct meaningful studies, patients with breast cancer needs to be included in basket trials. These basket trials enroll patients with different types of cancer, but with the same genomic alterations. And for the interest of time, I will speak about 2 rare mutations which are very exciting in the field of breast cancer and in the field of oncology in general. These are mutations in HER2 gene and in fusions of NTRK. So HER2 mutations seem like a real opportunity in patients with non-HER2 amplified estrogen receptor positive breast cancers. And this is a series of mutations that usually are present in the extracellular domain of the kinase that induces constitutive activation of the receptor. These mutations are sensitive to irreversible inhibition by HER2 tyrosine kinase inhibitor like neratinib. And as an example, this is the Smi Trial, which is a phase 2 multi-histology basket study. And what I'm presenting is the breast cohort that was treated with neratinib for HER2 mutations. The cohort included 25 heavily pretreated patients, and overall response rate was 32%. Clinical benefit, which is comprised of patients who respond and patients with stable disease, reached 42%. Median progression-free survival was 3.5 months. And actually, these results are a little bit disappointing. I mean, we should admit it that they are a little bit disappointing. But it happens there is bidirectional crosstalk between the estrogen receptor and between HER2 signaling pathways, where the estrogen receptor may mediate tumor progression in patients with sustained response to HER2 inhibition. So this trial, the Smi Trial, was amended, and now they are including an anti-HER2 therapy, they are including an estrogen degrader as an addition to neratinib. And here is an example of a patient that after response to neratinib progressed, and upon addition of fulvestrant, the estrogen degrader, resistance was reversed, and he continued to respond. After a while, he progressed again, and then a plasma circulating DNA was performed, and an acquired secondary mutation was found, again in the HER2 gene, and it was sensitive to another HER2 TKI, a stronger one called afatinib. So the more data accumulates, we learn that there are evolving secondary mutations. Now I'm moving on to this exciting fusions. These are the TRK receptor family that includes 3 transmembrane proteins encoded by NTRK1, 2, and 3. TRK are uncommonly expressed in normal tissues or in cancer, and fusions with one of these 3 genes may happen, and they drive overexpression and ligand-independent activation of the TRK receptor. Overall, the incidence across all tumor types is less than 1%. In a subtype of triple-negative breast cancer, these fusions are enriched. This type is secretory breast cancer, and definitely it is recommended if the pathology sees under the microscope a secretory breast cancer to go and look for this kind of fusion. Now, what's interesting that this study was published earlier this year in the New England with a total of 55 patients with 17 different types of cancer, and response rate to larotrectinib, which is an oral selective TRK kinase inhibitor, was about 75%, which is why this field is so exciting. And that's an example from the initial study presented last year at the ASCO for a patient who responded very quickly after several lines of ineffective chemotherapy to larotrectinib. The second concept is synthetic lethality, and this is usually, this is important because we have germline BRCA mutations in breast cancer in about 5 to 10% of patients. Synthetic lethality means that a single gene defect like the one in the BRCA enhances dependence on a second gene that can be targeted. So what happens in patients with germline BRCA mutations is that they have a damaged double-strand DNA repair mechanisms, and then they develop single-strand repair takes over. PARP is part of the single-strand repair. It's a key enzyme in that pathway, and by blocking PARP, we damage the single-strand with single-strand repair, and double-strand repair takes over. However, in patients with absent BRCA, that leads to cell death. And olaparib is one of the PARP inhibitors. Olympiad is the first phase 3 trial which demonstrated olaparib to be effective with progression-free survival improving by 3 months and doubling of response rate to 60%. This is another study with another PARP inhibitor that showed basically the same, very similar results. 2 more minutes. It's really the end. So the 2 other concepts, mutational tumor burden and deficient mismatch repair, they predict response to immune therapy with checkpoint inhibitors. Mutational burden means the definition is over 20 mutations per megabase, and there is a relationship between response and high tumor mutational burden. The fission mismatch repair now is approved by the FDA for treating with pembrolizumab. And today in the clinic, we use only 5 biomarkers. We have estrogen, progesterone, and HER2 receptors, and recently the BRCA1 and 2. But there are more opportunities for druggable alterations, but they are very, very rare. For the implementation of precision medicine, we need precision tumor genomic analysis. We need to test more patients and more clinical studies, compassionate programs for off-label treatments, and maybe, if there don't exist, a small fortune are needed to provide non-registered treatments. Thank you.
Thank you very much. Okay, we have time for one question. Okay, everyone for lunch. So I want to thank all the speakers. Thank you, Daniela, and thank you all the speakers. One. Go ahead. Go ahead. Whoever the last question. Go ahead.
I just wanted to react as a summary to what you said earlier before, and it's very relevant to the breast cancer as well. To look on the broad picture, on the micro and macro environment. You didn't talk about, macro environment regarding breast cancer, but I don't want to ask the question now, which is another, another topic. But just to mention, it's right, and I encourage very much the flagships and so on to take the data as you suggested. But I must say, being there, at least with the human brain, to combine clinical data is a big challenge, and today's really a nightmare. From the data, just to combine 2 hospitals, to the security, to the analysis tools that we don't have. We have a lot of big data, but it's really small, and thus the personalized and precise medicine, it will take a long way and a lot of effort still to be there to develop the tools to reliable prediction, replicable prediction.
Okay, thank you very much. With this, we go to lunch, and we come back to the hall at 2:20.